Okay, I'll go ahead and get started. All right. Hi, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly Impact seminar. Before we get started, I'd like to cover a few expectations. First off, today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I'll post the link in the chat along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, the next seminar will be on April 1st with Dr. Roz Schneider. And with that, I will turn over to Dr. Genevieve Melton-Mute to introduce our speaker.
Thank you, Andy. Good afternoon, everyone. I'm Genevieve Melton-Mute. I'm a faculty member in the Department of Surgery and Health Informatics at the University of Minnesota. On behalf of our Center for Learning Health System Sciences leadership, it is a true honor to have the opportunity to welcome Dr. Charles Chuck Friedman to our March Impact seminars to speak with us. Dr. Friedman currently serves as a professor of learning health sciences at the University of Michigan Medical School. He directs the Knowledge Systems Laboratory and has joint appointments in the Schools of Information and Public Health. He was the founding chair of the Department of Learning Health Sciences and the Josiah Macy Jr. Professor of Medical Education. Currently, he also serves as editor-in-chief of the Learning Health Systems Journal and co-chair of the Multinational Mobilizing Computable Biomedical Knowledge Consortium. Of note, Dr. Friedman was the founding director of the Center for Biomedical Informatics at the University of Pittsburgh, formerly, and also held the leadership role of Associate Vice Chancellor for Biomedical Informatics. He's also served in a national capacity as an executive at the Office of the National Coordinator for Health IT, ONC, which is part of the Department of Health and Human Services, really working to establish and advance certified health information technology and interoperability at a national scale. Dr. Friedman's been honored as a distinguished fellow of the American College of Medical Informatics, a founding fellow of the International Academy of Health Sciences Informatics, and he's an elective member of the National Academy of Medicine. As a pioneer and thought leader in the field of learning health systems, we're really thrilled to have him as this month's Impact speaker as he discusses the journey to becoming a learning health system.
Thank you, Genevieve, for that kind introduction. Let me just share my screen and we will begin. Okay, so just checking my slides are visible.
Yes, we can see them.
Okay, thank you. All right, so I'm very pleased to be here. It's a very exciting time for learning health systems, and I want to share what I know and what I have learned about what the journey is to becoming a learning health system. And I'll begin with a disclosure about the learning health community, which is a non-for-profit corporation with many of the same goals that we are all pursuing at our respective institutions. And I'll say a little bit about my own journey. Genevieve said a fair amount of that, but I'll talk about it as it relates to learning health systems. I did have two roles at the Office of the National Coordinator for Health IT, but it was really there that I discovered the concept of a learning health system. And I asked the national coordinator at the time, David Blumenthal, my boss, if I could make this big idea into a kind of personal crusade using my national position. And he said yes. And this resulted in into what I think is a seminal paper that really lays out a plan. It's not the plan that people are exactly following right now, but it gave a lot of visibility to learning health systems. I moved to Michigan in 2011 and initially was in the Schools of Information and Public Health. And there I did some things I couldn't have done in the government. I was able to organize several meetings, one on the core values underlying the learning health system, and the other on the sciences underlying a learning health system. And then in 2014, I literally got the opportunity of a lifetime to reorganize an existing department in the medical school into a department of focused on learning health systems and the sciences underlying high functioning learning health systems called the Department of Learning Health Sciences. And in 2016, we unleashed a series of strategic initiatives, a graduate program, a journal I'll say more about, a university-wide learning health system collaboratory, and a movement to mobilize computable biomedical knowledge as a key component of a learning health system infrastructure. I'll be saying more about many of these things in my talk. So this brings me to the main menu for today's presentation. If we're going to talk about a journey to becoming a learning health system, it makes sense to talk about what it is we're journeying to. So I'm going to share with you some visions of learning health systems. I'll then talk about something that's very important that people often ask me, so I just answer the question before it is even asked. What's different about this? Why is this such an exciting idea? And I will share with you three key points outlined in the bullets below that, to my way of thinking, make learning health systems distinctive. And then I'll close with the journey to becoming a learning health system as I see it and how we are applying this at the University of Michigan. So first of all, I like this very concise definition of a learning health system, that a health system of any size becomes a learning health system by acquiring the ability continuously and routinely to improve health by, key point, marrying discovery to implementation. And I can't emphasize enough the importance of this marriage concept, which I think is a great metaphor for what learning health systems are trying to do. If you want to read about learning health systems, I can recommend two places to go. One is the wonderful series of books and monographs produced by the National Academy of Medicine. And the other, this is the shameless commerce part of my talk, is the journal creatively entitled Learning Health Systems, which has been publishing articles on this topic for 9 years now and has achieved a significant level of visibility. We're very proud of the fact that in 2024, there were 142,000 full-text article downloads of articles from the journal. Now, another way to think about learning health systems is to think about music. Music is a wonderful way to stimulate your creative juices. And I would ask you to kind of think about a parade down a main street, such as the picture you see here of the May Day parade in Minneapolis. And imagine that one of the groups marching in the parade is the Learning Health System marching band and choir. And what would they be playing and singing? What would their anthems be called? And I want to propose uh, uh, three anthems to you that we are actually putting to music, thanks to a colleague at the University of Pennsylvania, Molly Cinderbrand, who's an ethicist and a composer. One of these anthems would be called Bring Us the Tough Problems. This is all about deep system change and solving the important, persistent problems that pervade our health and healthcare systems right now. The second anthem would be System Problems Need System Solutions. We're not going to solve these problems with Band-Aids. And the third anthem would be 17 years to 17 months, with a subtitle perhaps of to 17 weeks, 17 days, and even 17 hours. This, of course, refers to the well-established latency between the discovery of valuable biomedical knowledge and its widespread use in healthcare. Molly is putting all of these anthems to music. It will be recorded, and keep your eye on Spotify. Going along with this is a wonderful paper that appeared in the Harvard Business Review that, even though the term learning health systems is not used, I believe makes a clarion call for learning health systems. And if you haven't read this paper, I strongly recommend it to you. And I think the title says it all. To improve healthcare, fix the systems, not the people. Okay, so how do we fix the system? One way to think about it, again, using your imagination, think about an inspector who has landed in a health system somewhere with the task of figuring out to what extent this health system is a learning health system. And of course, all inspectors carry clipboards, and on those clipboards are checklists. So at a high level, what would be the items on this hypothetical inspector's checklist? What would they be looking for? Well, they'd be looking for whether what this health system does, everything this health system does, is captured as data, because without capturing it as data, you can't learn from it. The inspector would be looking for whether the system puts the data to use. Is it analyzed, converted to knowledge, and made an actionable knowledge that is made rapidly available to support strategies and decisions? Does it do this continuously, or is it bursty as a response to challenges, which would not, the latter would not be a learning health system approach? Is there an infrastructure that enables this to happen with the kind of economy of scale that infrastructures can provide? And finally, is this part of a culture? And it would be a culture of engagement wherein inclusive communities are the primary entities that drive the improvement. And this goes to the fact that, in my way of thinking, learning health systems are more about people and culture than anything else. A system property that learning health systems have is that they can exist at any level of scale, and they almost have a fractal property because they pretty much do the same thing at any of these levels of scale, from single organizations, large and small, from networks of organizations that come together to solve problems. Usually a set of focused problems will drive the agenda of a network. States, provinces, and regions can define jurisdictional uh, learning systems. And this is the state of Indiana, which has a learning health system initiative. So we've got the Big Ten here between Indiana, Minnesota, and Michigan. And then finally, whole nations can strive to become learning health systems at that level of scale. And here you see Switzerland, which has a Swiss learning health system initiative that's about to celebrate its 10th anniversary. And then, of course, there's this idea, which is still an idea, not a reality in any way, shape, or form, of a global learning health system. So how do learning health systems improve things? I would submit that they do this by affecting this marriage of discovery and implementation, whereby uh, the process focused on any problem of interest. And usually this is a system problem which requires a system solution, beginning with the formation of a multi-stakeholder learning community that will drive the entire process, continuing but with capturing current practice as data, doing one of the things that's on that inspector's checklist, assembling that data into a form amenable to analysis, analyzing that data to create knowledge or evidence that is specific to the domain in which this learning community is operating, but then integrating evidence that is external to that domain, probably from the literature, and on the assumption that this problem, this major system problem that drew the attention of this community, has been studied elsewhere and often studied extensively. So here, these two kinds of knowledge, these two kinds of evidence are merged and interpreted by the community, which then decides what it wants to do about it, which could be one intervention or multiple interventions. Those interventions are implemented, and this initiates the second iteration of the cycle where new practice, because the system has changed, is captured as data. The extent to which things have improved is ascertained, and the improvements are related through successive data assembly and analysis to understand how further changes and improvements can be made, and so forth. As one quick example, we have been working for many years now using this approach to improve against about the most wicked system problem, well, not the most, but one of the most wicked system problems I could think of, and that is how to improve the survival rate from out-of-hospital cardiac arrests, which in Michigan sits at around 10%. And we formed a learning community to do this. We gathered a lot of data. We assembled this into various analytical data sets. We analyzed the data. We generated our own findings based on the studies we did. We integrated this with external evidence. We used a method called deliberative dialogue with the learning community to develop ideas, and came up with an intervention called a heart safe home, which, if we have more time, I'd be happy to discuss with you. And we developed that into an initiative which we are now implementing, initially on a small scale, but hopefully on a much larger scale later. The American Heart Association has actually taken significant interest in this. So to kind of wrap up these visions of a learning health system, uh, the point to emphasize is that better health requires this marriage of discovery and implementation, and not a kind of short circuit that reflects a lot of what goes on in biomedical research these days, namely discovery only, where data is converted to knowledge. That knowledge is published in a journal, and it just kind of sits there with nowhere to go. And the people who did that particular study then go back, uh, collecting more data, converting that to knowledge, publishing it further in a journal, and so on and so forth. That's not what a learning health system is. Nor is it this. And this is what a lot of institutions do, and to some extent my own, and I'll say more about this later. This is a well-intentioned attempt to marry discovery to implementation and do the kind of cyclic activity I've described earlier, but the cycle is broken because each of the components of this cycle are carried out by different entities within the organization, and there are then need to be handoffs. And I think we all know in the Big Ten that when there are handoffs, there are fumbles. And this is a method that has the right intention, but often fails in the execution. So now, having shared some images of what a learning health system is, uh, I want to preview the journey a bit and how I see the journey to becoming a learning health system occurring. The key point here is that a learning health system, even though I've talked about cycles, is much more than just a collection of cycles, with each of them functioning as a tub on its own bottom. A mature learning health system is a pervasive cultural phenomenon that pervades an entire institution. If we're focusing on a organization, a healthcare delivery organization becoming a learning health system. I'll elaborate in a moment on this, but the way the learning health system operates is through many of these improvement cycles that co-occur at different rates, addressing different topics, but all supported by a shared infrastructure, which is one of the things that that inspector would be looking for. And finally, I'll introduce this idea of a strong positive feedback effect where growth takes place not through top-down processes, but what I call organic infiltration, driven by a positive feedback loop between improvement cycles, infrastructure, and culture, each one as it grows, making the others stronger. So what makes this approach different from other approaches? I'll discuss three aspects of this, and I've written further about this in a short article that appeared in Learning Health Systems in 2022. So the first is this idea of embracing uncertainty. These learning cycles that are carried out under the aegis of a learning community uh, begin with the community not committed to any improvement intervention. Basically, this is not a implementation strategy as much as it is a eventual implementation strategy guided first by discovery. So throughout the cycle, the community advances by discovering together, and it follows that one of these cycles, if done according to these precepts, will begin down here at 5 o'clock and commencing with studying what's going on now, analyzing those data, and so forth, beginning here and not here at 12 o'clock, where the community has been told what to do and comes into action, having being given orders to do this or do it this way, or maybe both do this and do it this way. This is not executing the marriage as conceived as a core idea of a learning health system. The second unique characteristic, or distinctive at least characteristic of a learning health system, is the idea that the community that discovers is also the community that implements. I've already alluded to this by saying that the learning community drives the improvement cycle. So a way to think about it is that this community, the same community that does the performance to data or green part of the cycle also does the data to knowledge or blue part of the cycle, and also does the knowledge to performance or knowledge to practice part of the cycle, kind of changing colors, as it were, throughout as the process progresses. Of course, this community may not have all the specific expertise needed to within itself to do each piece of the cycle, and might bring people in with this expertise to help them. But there will be a core of this community, to my way of thinking, that persists and follows and drives the entire cycle. This contrasts with that interrupted cycle uh, situation that I talked about before, where each piece of the cycle is done by a different organization. And these people who specialize in the studying the performance and taking it to data might be called program analysts. The people who just do the discovery to knowledge might be called health services researchers in a given organization. And then the people who implement might be called change implementers. And to the extent that these different roles are inhere in different components of the organization, each with its own leadership and culture and possibly its own priorities, this is a different and I think less effective way of undergoing improvement with the continuous work of the learning community. And again, this, I believe, is a distinctive feature of learning health systems. The third distinctive feature is this idea of infrastructure. So these cycles I've talked about can enable improvement, but if they operate independently of one another, if each functions in its own little silo, yes, you have improvement. Yes, you have cycles, but you don't have a system. And you can think about this by analogy by saying, well, you've got a nice river in Minneapolis, and if you want to get a lot of people across that river every day, you really have a couple of choices. You can ask everybody to row themselves across with their own rowboat, or you can build a bridge. And obviously, the infrastructural approach to this is to build a resource like a bridge that every entity can use. So the challenge of this for learning health systems is how do we enable a large set of these co-occurring cycles, each functioning under the aegis of its own community, also addressing a unique problem, to function as a scalable and sustainable system. And it's depicted in this diagram how this might be done. You create an infrastructure which delivers a set of services, some of which have to involve people, some of which involve technology, some of which involve process, and some of which involve policies, a socio-technical infrastructure that provide services to all of these cycles, taking advantage of the fact that in just the same way that everybody who's crossing a bridge is going to somehow get to the other side. Each of these cycles is doing the green to blue to red thing. They're not doing it in entirely the same way, but they're all doing the same thing. And as such, they can take advantage of these services, which are designed to support the green and support the blue and support the red. I don't have time today to go into more detail about what these services are, but I can direct you to a 2024 paper written by myself and three wonderful colleagues that describes these services in much more detail. So now the journey to becoming a learning health system and a bit about the Michigan experience as I've been privileged to participate in. So here's this positive feedback diagram that I introduced before. And I do believe this represents how the system grows. You can start anywhere, and the stimulation, the positive stimulation, can flow in either direction. So the number of concurrent cycles ongoing in the environment can improve the penetration of the culture of learning health systems. Uh, the number of concurrent cycles increasing can stimulate a great number of services provided by the infrastructure, or more mature services provided by the infrastructure, which can also increase the penetration of the culture. I think I don't want to belabor this point. I actually think that the figure is pretty self-explanatory, but I did want to emphasize that the connections can go in either direction, and this is kind of how a turbojet works, or a turbo in your turbo-powered vehicle. I believe that the journey to becoming for an organization to becoming a learning health system is one of what I call organic infiltration and not inoculation. You cannot, in my opinion, top down by edict of the CEO, make an entity into a learning health system. In 2014, after I became the chair of the Learning Health Sciences Department, I went to the dean who made this offer of a lifetime and said to him, okay, now that we have the department up and running, when are you going to announce that the University of Michigan health system is on a mission now to become a learning health system. And he couldn't stop laughing. He said, if you want this to fail, I will do that. But I can tell you that would be absolutely the wrong thing to do in this or any other academic uh, health center. Build this up from the bottom, get some things started, and as these things grow and take hold, it's just going to happen. And that's where, although I didn't know that term of organic infiltration at the time, that's when the seed of it was planted. So at an early stage of development of a learning health system uh, within an organization, it may the existence of this positive feedback loop um, will not have a great visibility. It may even be almost invisible as you see it in this picture. But as it grows, it will become more visible. And as it grows even further, it will become even more visible. And the institution will look like a learning health system. That's what's going to be much more prominent. Many people have said that the ultimate goal of a learning health system or a learning health care system would be the ability to learn from every patient. And I would argue at full organic infiltration, when the situation looks like this and not this or this, in that limit, the system is truly learning from every patient, just as in aviation, which I believe is the quintessential learning system, the system learns from every incident and every accident and improves as a result. So, a few other things I've learned as I have visited many entities and spoken with many people. Uh, while I've talked about a general approach here, I want to emphasize that if you've seen one organization, you've seen just one, and every organization is going to start this journey in a different place, building on what's already there, the culture that exists, and many other factors. I've already mentioned that this is the approach is antithetical to top-down uh, methods and it's infiltration over inoculation. You can't inoculate uh, an organization with LHS serum. It just won't work. That said, the idea is an easy sell. It's very easy to get people interested in a concept of learning health systems. And one way to understand this is to recognize, is to take the name apart. Who is against learning, who is against health, and who is against the idea of improving by system methods. I would argue that almost no one is. And if you want to put together an idea that just about everybody will see value in just from the name, try learning health systems. So the idea is an easy sell. You can get people's attention with this idea. I hope I've kept your attention through this talk. Now, an important thing I've learned is that a successful process of infiltration needs a commons. It needs a place where the people interested in and participating in learning health system work across an institution can come together, see each other, and communicate. Uh, I'm proud of saying, and I'll say more about this later, that I think starting a commons, what we call the LHS Collaboratory at Michigan, might have been the best move we made. Uh, pick a little bit more, picking up on this idea that everyone starts in a different place. Many institutions have many of these infrastructure services already in place. If you take an inventory and if you look at the services detailed in that article I referred to, I think you're going to realize that many of these things are already in place, and the task in hand is just to stitch them together. And I use just, fully recognizing that the stitching can be a significant challenge in and of itself. Um, it's very important that all the improvement cycles be connected to the infrastructural services and not operating with their own mini service infrastructure when they could take advantage of what the organization as a whole provides. And I, if I've learned anything in doing this for the now almost 15 years I've been thinking about it, folks, information technology is the easier part of putting this in place. Uh, the LHS Collaboratory at the University of Michigan started in 2016, and the way it works is that even though everybody is welcome as individuals at LHS collaboratory activities, and 1,500 or so different people have participated to date in these activities over these 9 years. Really, the members of the collaboratory, as we set it up, are LHS related projects, and we currently have 29 such projects, each one with a seat on the collaboratory steering committee. And the steering committee decides the directions the collaboratory will take, and the events include speakers, poster sessions, workshops, sharing, and we think that while a great deal of information is conveyed at these sessions, it's getting the people together that probably has as much, if not greater, effect on moving the process forward than what knowledge is transmitted at those events. So a little more detail at Michigan, we have a number of ongoing improvement cycles. We have a number of infrastructure services. Our CTSI is very engaged through an implementation science network, which really is kind of a component of the infrastructure, and a data standard service, which is very much a component of the infrastructure. Um, the Department of Learning Health Sciences works very hard in developing learning communities in support of specific improvement projects. Uh, we had a big breakthrough when the dean himself, soon to be the outgoing dean, uh, uh, took note of the fact that Dr. Ed Hurwitz, who you see pictured here, who was the outgoing chair of PM&R, had been doing a lot of learning health system work in his department. And he said to Ed, now that you're not going to be a chair anymore, why don't you continue your learning health systems work? And we'll support you to do that. And that gave rise to Ed being named the first clinical champion for learning health systems. We are minting him a medal to wear, but we haven't completed that process yet. And another emergent role are a few, two or three at the moment, departmental associate chairs for learning health systems. And then we have one of the P30 grants from ARC and PCORI for learning health system development. We call ours MELSTAR, because everything at our institution, and I'm sure at yours as well, needs to start with an M. So bringing this to a close, and I think, all right, we're right at about 40 minutes. So just a few sound bites in closing. When we talk about visions of a learning health system, I tried to present many visions to you, but the take-home point that I'd like you to remember is this notion of a marriage between discovery and implementation. The distinctiveness comes from three factors to my way of thinking: embraced uncertainty, this idea that the learning community starts out with no pre-commitment to a particular intervention, the continuously engaged learning communities, and the infrastructure that makes the system a system. This idea of services supporting multiple simultaneous cycles in the same way that a bridge can carry many kinds of traffic from one side of the river to the other. And finally, the idea of the journey as characterized by this infiltration process through which improvement cycles, socio-technical infrastructure, and culture supporting each other can lead eventually to to pervasive transformation. Okay, so that brings my remarks to a close. I would be thrilled um, to hear your questions, comments, disagreements, or anything else you would like to say in response to these short remarks. Thanks very much.
Awesome. Well, thank you all. We have about 20 minutes remaining for the Q&A. If you have any questions or comments, please use the raise your hand feature. We also welcome you to type your questions into the Zoom Q&A. And it looks like to start, so Sheila asks, how do patients participate in the LHS at the University of Michigan, and how has their participation supported or hindered your progress?
They are supported primarily as members of these learning communities. We would not think of starting a learning community without patients. So we, for example, have started a learning community focused on bipolar disorder, and both patients with persons with bipolar disorder, and in some cases, members of their families are part and parcel of the learning community and co-create whatever the learning communities do. Uh, that is that is the primary way, and you can go through these you can go through these learning community activities and see where the patients are. We don't, we have not created although it would be something worth thinking about, a collective or of the patients participating in learning communities across these various undertakings, but that might be an interesting thing to think about. They are typically compensated um, to varying degrees. In some cases, just for their travel expenses to come to face-to-face meetings, but more commonly, they are paid a stipend for their time.
All right, it looks like we got a related question. So patients are vital to inform the learning cycles, but building these infrastructure bridges takes more energy and intention to build. How has the University of Michigan navigated finding sufficient resources to meaningfully involve patients?
Uh, so uh, I'm trying to understand the question. Patients are not involved typically in these infrastructural services. The infrastructural services, for example, let me take that back. The infrastructural services that support the development of learning communities uh, do include some patients who have worked in these learning communities and are interested in helping other patients get involved in other learning communities. But by and large, the infrastructural services are data services, knowledge services, implementation science services, policy services, and that is the bringing of expertise to to the support of multiple cycles. And patients would not typically, except for that one exception I talked about, be involved in that.
It looks like we got another question. Can you say a bit more about the role of the clinical champion?
Sure. This is evolving, but a few things have happened. Number one, the head of our CTSI has committed resources to put a set of supporting staff in the to work with the clinical champion because Dr. Hurwitz's time can only be sliced and diced so many ways. The clinical champion has become a co-chair of the LHS Collaboratory. The clinical champion has convened a subcommittee of the collaboratory focused on making implementation into the clinical environment work to come up with strategies that might generalize across improvement efforts, in effect forming another kind of knowledge infrastructure uh, for the uh, for the collaboratory and for the institution. Um, he's writing a couple of grants to get foundation or federal support for some of these activities. He's still working with his own department as kind of a legacy activity now that he's moved into an institutional role. So, yeah, he's really hit the ground running, and I think his role is still evolving, but it's really off to a good and important start. Oh, one other thing, he's become a faculty member in the Department of Learning Health Sciences, where he can directly interact with the other faculty and staff of the department. And given the department's mission, that will be fulfilling in both directions.
Next, Dylan says, excellent presentation on LHS. Does LHS require health information exchanges with technical linkages to bridge patient electronic records in acute care hospital settings and primary care clinics?
That's a scale question. That depends on the scale of at which the system operates. Certainly, learning health systems that are networks of different organizations, such as Improve Care Now and PedsNet and and EpiNet, uh, funded by the Mental Health Institute. Uh, those absolutely require health information exchange among different institutions. PCORNet was designed to uh, to enable that kind of data sharing, but where the institutions don't belong to a common data sharing infrastructure, that's going to have to be created. When the scale of the system we're talking about is within a single institution, usually what we think of as health information exchange that occurs across the boundaries of different institutions isn't required. Now, I think just about everybody who works in a complex academic healthcare environment knows that the problems of getting the data you need, data that is fit for purpose, uh, is still a challenge even within a single organization. So as I said at the beginning, this is a scale question. The larger the scale in terms of what's encompassed by the system, the more health information exchange is needed. In Indiana, where they have a statewide, very mature and very successful health information exchange, excuse me, the Indiana Health Information Exchange, I think that's one of the reasons they feel like they could have a statewide learning health system project because just all of the institutions that provide healthcare in Indiana are knitted together in a way that they can share information, and that's a big infrastructural head start.
And it looks like we have another question from Genevieve. So how does the University of Michigan LHS leadership navigate competing priorities and governance with LHS and health system initiatives?
So, well, we don't consider them competing. They do different things. I mean, we have a very strong quality improvement department, and the quality improvement department is headed by someone who is a believer in learning health systems. And I think that the scale of the problem that the learning health system uh, activities address is different from what the quality department addresses. The quality department addresses problems that are more tactical, need quicker solutions. You could argue they use a very similar cyclical kind of process, uh, but they are fundamentally different kinds of problems, whereas out of hospital cardiac arrest, standardizing care delivered in the PM&R department, helping newly diagnosed uh, persons with bipolar disorder function at a higher level are more system problems that are going to require and are requiring much longer periods of time to address. And back to system problems need system solutions. Genevieve, did that answer your question?
It did, although I would say sometimes health system resources are needed um, within the health system infrastructure. So the ability to successfully garner those resources and attention units.
Yeah, thanks for that elaboration. We've been fortunate in that I don't know what will happen next week or next year, given the things that are happening in the country. But we've been fortunate that the resources in our health system have been adequate, more than adequate, particularly in the area of investment in information infrastructure. That we haven't had to build a lot of that out from scratch. Uh, but it's been a matter of connecting these improvement projects to this infrastructure that's been the primary challenge here.
Next page says, "Hi Chuck, what do you think about the opacity inherent in AI tools for LHS, specifically related to the proprietary and adaptive natures of many AI tools? It seems like this opacity might put up some barriers to effective LHS, and it would be great to hear your thoughts about the degree to which that might be true and how we might mitigate it."
Yeah, thanks for that question, Paige. I It's something that I've been giving a lot of thought to, and uh, my way of thinking about it is reflected in something that's percolating in my head, and I've talked about a few times, is uh, that LHS and AI need each other. So my thinking about this is that uh, you can take the LHS infrastructure and use it as a template for uh, deploying AI solutions, and the infrastructure brings up the right issues and the right concerns, like part of the policy infrastructure is and ethical infrastructure will require the right questions to be asked uh, as part of the deployment. So there are lots of ways, to my way of thinking, that if AI applications are going to be successful in improving health and healthcare, they need to be connected to, whether it's called this or not, an LHS infrastructure with many, if not all, of the services that an LHS infrastructure can provide. Flipping that around, the LHS needs AI because clearly the power of some of these AI applications, if appropriately deployed, can lead to much stronger intervention. So I would like to see this portrayed as another complementarity and even another form of marriage of AI and LHS, because each one really needs the other to be as successful as it can be. The opacity um, is specifically, because you asked about it, is addressed in this way because if a learning community is part of the cycle that is going to implement AI as part of the improvement solution, the questions, the concerns about opacity are going to come up, are going to rise up out of this multi-stakeholder community. And I don't think they're going to tolerate the implementation of a solution that is so opaque that it ultimately cannot succeed in a way that is satisfactory to the people it's designed to serve. Much more about that we can talk about at some time, I hope.
Well, thank you, Dr. Friedman, for taking the time to give this talk, and thank you all for attending. Again, in closing, please join us for our next seminar on April 1st at noon Central Time. This concludes our presentation. See everyone next time.
Bye. Thank you, everybody.
Thanks, Chuck.